All right, I'm getting this done about a day late, so I apologize. Hopefully you'll have some time to review these slides prior to Tuesday when you'll have your first small group session with your students. Thank you again for signing up to facilitate small groups with the healthcare systems course. This is the, I think, third academic year that I've been running this course, and I've been trying to change it up a little bit each time. I definitely think that I could do better, so I do really appreciate your feedback. A lot of times it's like little things like typos or just details about the case that I forgot to include. But if you have any big picture things or resources that you feel are beneficial, please send them my way because I really want to make this fruitful learning experience for the students. So today we're going to talk about the objectives of the course, the case-based transfer activity. You should all have a copy of the leader guide. We'll clarify the schedule and some of the activities that they'll be doing. I'll show you the evaluation form, and then obviously I'm recording this, so you can't ask me any questions, but you can always email me. But thank you for doing this. So this course came to be a few years ago when they revamped the curriculum, making the semesters more distinct. This used to be something that used to be was a longitudinal course where they would do like a half day during like once a month or something like that, and it was really hard to give the students a good experience just based on being pulled in so many different directions. So now it's actually carved out for its own week. The six tenets of the healthcare systems course is to talk about clinical reasoning, the U.S. healthcare system, patient safety, quality improvement, teamwork, leadership, and communication in healthcare, and the economics and management of chronic disease. There's some other ones like leadership skills, self-directed learning, and then professionalism. So this curriculum focuses on one particular case to really reinforce the concepts of the large group sessions that are pre-recorded and available for the students to review on Canvas. So essentially, the students will spend all of Monday watching videos and doing quizzes to learn some of these key concepts. So each one has like its own related video, anywhere from like 30 to an hour in length. And then they'll do a quiz. There's one that's actually like an AMA case because I think it's a really good one and was better than anything I could have come up with on my own. And then on Tuesday, Wednesday, and Thursday, they will have their small group meetings with you, which will work through different aspects of the case. And again, your role there is to be facilitators, not teachers. So you shouldn't be answering all the questions for them. They should actually come prepared and have the worksheet generally completed prior to meeting with you so that they can review their answers with you and you can just provide some, discussion points, expert opinion, and kind of just be a resource for them. So you're not supposed to be teaching them anything. And if they're not prepared, I want to know about it. And then on Friday, each group will present a practicum where they'll have researched something related to the course and present a 15-minute presentation. Okay, so jumping into what you guys are going to be doing, you're mostly going to be working through this case. And the case is a guy named George Anderson. He's completely fabricated, not a real patient. But he's uninsured and basically has developed heart failure in addition to diabetes. Basically, they're going to get the same case as you. The only things that you're going to see that they won't have is going to be in red. So if you print it off in color, you'll very easily be able to tell what you can see and what they can't see. The 3 different days focus on different parts of the case as it progresses. So basically, the first meeting will be about assessing and admitting the patient. The second day will be kind of the hospital course and what transpired over the course of the hospital stay. And then the third part of the case is preparing the patient for discharge, taking into account that he now has a chronic disease. Like I mentioned, the students are expected to complete the worksheet and be prepared to discuss their responses with you during the small group session. So I'm just going to walk through the major points of each session, just so you're a little bit more prepared. A lot of this is available in the workbook for you or the leader guide. So you can definitely read that, but I'm just trying to kind of hone in some of the key points. So the learning themes for the first session are going to be on clinical reasoning and quality. So eventually I'd love to turn this into an SP exercise. I just haven't had the wherewithal to do that yet. So hopefully maybe next year I'll be able to. So what they'll have is a printed thing of the case, just like you guys do. And then they'll use some of the resources that I provided for them to develop a problem representation, use diagnostic schema to aid in the differential diagnosis, and to create an illness script for their top differentials. And it's a pretty clear-cut case of heart failure, so it's kind of hard to sometimes expand their differentials, but you can kind of be there to really probe. Your job is to facilitate the discussion, highlight some of the clinical experience that you have in, assessing patients like this, and give constructive feedback on their reports. Again, you don't need to be teaching them about a differential for shortness of breath. This is just an example of the things that they'll be working through. So trying to, create a problem representation that is going to be concise, that uses precise medical language, identifying key clinical findings. So really the things that are going to increase or decrease that post-test probability of the disease. So like fatigue is not going to be really helpful in this case, but like an S3 will. And when we talk about a summary statement, I really like for them to include the context, including like the past medical history that's relevant, the temporal relationship, is this like an acute or chronic subacute, and then the key findings of the case. That's what they should include in their problem representation or summary statement. They should have a problem list as well, so that's not just the thing that they're presenting with. And a lot of what I emphasize in the lecture is to prioritize the problems, but then also, some things might be able to be lumped together. So like if the students are astute enough to identify that the patient has like, left-sided heart failure, then they can put all of those together instead of doing, like pulmonary edema as one of them and crackles as one of them and dyspnea as one of them. They can put those together into one key thing. And then when in doubt, you can always split those up. And then the way that they should be ranking their differential diagnoses is in these 3 tiers. The first one being that is a high clinical likelihood, the one that's kind of the most likely to match the illness script without any sort of rejecting features. Tier 2 is going to be those kind of, more moderate clinical likelihood, again, 30 to 50% pretest probability. So they might miss some key features and you can't really explain it fully, but there are some things that really make you think about it. And then the low clinical likelihood is basically something that like the patient doesn't have that, but you might have just thought of it, and there might even be some rejecting features. We have this concept of like a tier 1B, which is those never misdiagnoses. So they should be able to identify some things that you wouldn't want to miss in somebody who comes in with shortness of breath. So then they're going to move on to ordering putting in admission orders for the patient. I gave a little mnemonic in the facilitator guide for you guys because most of us are used to EMRs now. But the main thing is to emphasize high value care and avoiding over utilization of low value services. So really challenging each student at every point to justify why they're ordering a particular test or treatment for the patient based on something like a guideline or some clinical discussion. So not just like over ordering everything just because they're available. And they're also going to be researching the cost of each of those tests so they can really estimate how much it's going to cost the patient out of pocket. And then we'll just talk about some common heuristics. One of the big things that we emphasize a lot in the lectures is the 5-step framework for high value care. It's kind of intuitive that you want to only order things that are going to be beneficial and not things that are going to be harmful or costly. But a lot of it is also like customizing a care plan that takes into account the patient's values and concerns, um, and like kind of downward moving more towards system level opportunities to improve things overall. Again, going through the estimated costs, this is something that we don't do a really good job of, is like being understanding of how much things are going to cost, particularly out of pocket for patients. The web-based resources are not really great. There are some like general searches that you can find, but there's nothing that's like a society-based or government-based that we can use. I did find an article recently, I think it was like 2019, that indicated the median cost of heart failure hospitalization is around $15,000. But this guy's is probably going to be even more because he has a new onset of heart failure and he's going to have a lot of additional workup. And then I think it's also important to emphasize that, he probably is going to get some help from the hospital where they have like these patient assistance navigators, help set up a payment plan, but he's going to have a pretty big bill. And then I also like to emphasize about how the HRSA, or Human Resources and Services Administration, has the disproportionate share hospitals, of which I think all of us are working at, and they get additional funding to kind of cover the lost costs of providing care to indigent patients. And again, just emphasizing that this patient's probably still going to be financially impacted by this hospitalization, and the hospital is probably not going to make as much as it would like either. I like to emphasize a few different heuristics when it comes to the clinical reasoning. So the first one being availability bias, which is kind of the tendency to judge the likelihood of a disease based on the ease with which it comes to mind. So like if you saw something very recently and this kind of looks like that, you might think that that's the same diagnosis. Or I always use the example of like this old lady that I had who was losing weight and all of her initial workup was negative and she ended up having ovarian cancer. So I'm always like trying not to order a CT scan of the abdomen and pelvis on every old lady who's losing weight. Anchoring is when you prematurely settle on a particular diagnosis early in the workup, and then you basically stop responding to any new information that comes in that might be pointing to something different. Kind of goes along with like diagnostic momentum. Confirmation bias, which is also similar to anchoring, is the tendency to only notice evidence that supports the initial diagnosis and you ignore any information that might negate that. So you put more value on the things that are confirming what you think, and less value on the things that go against it. So the second case is the hospital course, which focuses on patient safety and teamwork. The focus here is to focus on review potential errors in the patient care and identify some system level opportunities to prevent them in the future. The three things that I wanted to focus on was like that this guy kind of had an inappropriate indwelling catheter, symptomatic hypoglycemia, and iatrogenic AKI. All three of these things were not necessarily like significantly impactful. There wasn't a lot of morbidity. A couple of them were actually just like near misses. But when you think about it, there should be something that we pay close attention to so that we don't harm patients in the future. Students will also be expected to complete a fishbone diagram for at least one of these errors prior to the session, which I have provided here and in the manual, and suggest some system level opportunities to prevent these. It should be a really good discussion, and you can add some experience and safety concerns and interventions based on your clinical expertise. So the three safety events. So the first one is that the fact that the guy became hypoglycemic the morning he was supposed to have a stress test. This is probably mostly due to provider-based knowledge issues, where they basically escalated the sliding scale and basal bolus to be too high based on how much he was receiving. And then also not adjusting for the fact that he was going to be NPO. But this could identify maybe system level opportunities to, maybe trigger providers to not go up so high, or maybe have, a pharmacy take over the adjustment of insulin, because a lot of times I feel like they could do a better job than we do. But just you can get creative with interventions that you suggest, or maybe things that you've seen before to mitigate that. The patient also gets an indwelling catheter put in, and I have the guidelines here for like, why you would put in a catheter, but he doesn't meet any of them. It ends up being because of a verbal order from a cardiologist. And so, the issues around like consultants putting in orders for things, and maybe, who's expected to sign off on verbal orders. And then, the attending didn't even notice that there was a Foley catheter in place. So, just making sure that you keep up with the whole like this idea of culture of safety, and, making sure that people speak up if they see something that they don't think should be there. And then the patient also gets an acute kidney injury in the setting of like aggressive diuresis and contrast. There might have been some early signs with a kind of upticking bicarb and BUN, and they never really reevaluated the diuresis during the admission. So, that should be something that might need to be evaluated on a day-to-day basis, especially in somebody who's new onset heart failure. And then it just emphasized how AKI can impact care with like delays in discharge, and the risk of long-term CKD. A big thing is about just culture. Students are supposed to kind of understand what that means. It is an organizational culture in which frontline staff feel comfortable disclosing errors, even their own, while maintaining professional accountability. Providers shouldn't be held accountable for system failings, but the whole idea of no harm, no foul should not be part of the culture. So, those near misses can be really helpful to implement systemic change. And then again, that kind of goes against things that are like, like gross misconduct. So people who like unintentional or like intentionally override the system and do things that they shouldn't be doing. But there are a lot of times where you might just develop unhealthy habits, like shortcuts and workarounds, the whole click fatigue where you ignore those alerts that pop up. Those are real things that we deal with on a day-to-day basis. And then just take some time to discuss how safety events are reported at your facility. So for example, using like vigilance in Memorial. You might even want to share some personal experience that you have with these. This is just an example of the fishbone diagram. You can instruct your students on how they're going to do it as much as you'd like to, but the students really should have this prepared before they come in and work with you. And then the second part of this case is just the students need to do some independent research on the different roles of team members to discuss, and then really emphasize times when these team members have been vital in providing good patient care, and maybe how they could have been useful in preventing errors in the case of Mr. Anderson. And then of course taking into account the leadership traits that are essential, which I included for you in the manual. The last part is that the students are going to practice communicating the error. So the first one is just doing the standardized SBAR documentation, which I included an example, but you can kind of feel free to work it however you want with students. And then I just included a framework for discussion of errors, and basically includes explaining what happened, be very straightforward with the events that led up to what happened, apologize when it's appropriate, communicate how the health impact will be minimized, and also how it will impact the patient's future care, and also discuss ways that you'll try to minimize this happening again. And then the third part of the third meeting of the week will be on Thursday, and then you'll be preparing the patient for discharge. And this is where we'll talk about the U.S. healthcare system and chronic disease. It incorporates some of the elements of the two previous sessions, but is really focused on, the discharge of a patient who doesn't have insurance in a system that really isn't designed for people who don't have insurance. So they're going to write some discharge orders. We're going to focus a lot on medication reconciliation, like which medications you should prescribe and where and how the patient's going to pay for them. But also doing some research into the local federally qualified health centers in their area and understanding some of the resources that they provide. So you might be able to provide more insight, particularly at Macon and Columbus, because I'm not as familiar with the ones that I included in the leader guide for you. Students are going to estimate the cost of different prescription drugs, taking into account some of the quality measures that we have for heart failure and the patient's financial resources. And then this should really be a good discussion about real world management. Finally, you guys are going to be asked to complete an evaluation on each student on a scale of 0 to 3. Basically 2 and 3 are satisfactory or exemplary, and that's passing the class. And then if they get a 1 or a 0, they're not going to pass, and they're going to have to do some additional work in order to get credit for the course. So they'll be evaluated for timeliness, preparation, communication, attitude, and participation. You'll basically complete that after your final session on Thursday and turn it into the, you can leave it on your desk and the administrative support will come pick it up from you. You'll also get evaluation requests on 145, but these are actually going to be recorded for you if you do it on pen and paper, so you don't have to worry about those. And then again, like I said, they have to get a 2 or 3 in each domain to pass the session. So if you have any questions, you can call me, text me, email me. I'm working clinically as well, but I'll try to break away to help triage any issues you might have. But again, I thank you again so much for doing this, and I really appreciate all your feedback. Thank you.